We're going to get started. Bonjour, bienvenue à Montréal, de la part des co-présidents des sciences sociales. So hi, Montreal, welcome to Montreal from the co-chairs of social science. My name is Marie-Lou Gagnon. I'm an associate professor in nursing at the University of Ottawa, and my co-chair, Mylène Frenette, who's a professor at UQAM. We're both co-chairs of social science, and it's our great, great pleasure to welcome Dr. Laurel Sprague. Her name actually came up the first thing when we were asked to suggest names for this plenary. It is a great honor for me to introduce you. I will read your bio, but I just have to say you're definitely one of my role models, and it's a pleasure to have you in Montreal. So thank you so much for being here. Dr. Laurel Sprague is actually a global research fellow on HIV, gender, and justice at the HIV Justice Network, specializes in human rights, political representation, and legal frameworks impacting people living with HIV. Her current scholarship focuses on restorative justice, gender equality, and comparative advocacy. She is the former NGO Delegate for North America to the UN HIV/AIDS Program Board, representing diverse networks of people living with HIV and civil society organizations. She has been an honors college senior lecturer at Wayne State University and an adjunct faculty member at Eastern Michigan University teaching political and feminist theory. She holds a PhD in political science, and I'm really, really excited to say that she's the newly appointed ED of GNP+. Thank you, and I'll give you the mic and take your full 45 minutes.
I think I have an hour and 45 minutes. That's what the slide said, although it was a mistake. Don't get scared. Okay, so thank you so much for having me. Thank you both for inviting me. This is a big honor and a huge pleasure. And I really also want to thank everyone who has given me so much support with the announcement we made this week of my new position with GNP+. We'll need all of your love and support, and we're about to do some really, really good things by and for people living with HIV. So thank you very much for that. My slideshow today, actually, sorry, I need to look at the English one. Okay, which is only over here. If I could have the English version down here, that would help. It would help with my comprehension of my own slides. Thank you. I was reflecting on the title of the conference. We're not there yet, and I thought that was a perfect title, and congratulations to the people who named the conference that, because we've made tremendous progress in HIV, and it's very clear that we're not there yet, and that we have some hard work to do. And I just want to preface my remarks by saying that I know people in this room know as well as anyone that we've already done really hard things. So when I say now we do the hard part, I don't in any way mean to say that we haven't had to do some really hard things, and that we haven't already, many of us, experienced a lot of grief, that there isn't a lot of trauma, and that we haven't already done hard things and got up and kept going and done more hard things the next day. And so I want to recognize that, that we've done that. And then I want to say, and I think everyone here knows this as well, that we have a lot of hard work left to do. And so just to give an overall sense of what I'll be talking about today, my message to you is that we can celebrate, and we should celebrate, the tremendous biomedical advances that we've made. And at the same time, having made these advances really shows us, I would say in a kind of stark relief, how much we still have left to do. We've made all of the advances that we've been asking for the last almost 4 decades, and yet we have so much work that's still left undone. And the work that's left undone is work that is grounded in human rights and a human rights approach for people living with HIV and those people who are most at risk of becoming infected with HIV, of acquiring HIV. And until we take a look at ourselves and the other people in our medical and research communities, and figure out what it is that makes it so hard for us to turn around and treat people with compassion and justice and decency and make sure that we provide care in a non-judgmental way to everyone who needs it, we're never going to get to the end of this epidemic. The biomedical tools won't get us there. And so that's what I'll be talking about today. And, okay, so apparently I'll be learning French while we go, which it's a goal of mine. So, I've already sorry, I'm taking you back. We're going back again. Okay. I actually wanted to speak about my second, my subtitle here. In my field of political science, there has been a long conversation, a long research agenda on the concept of political tolerance. And the focus of that is this, what we call the paradox of tolerance, or the tolerance paradox. That on one hand, we see citizens in democratic countries saying that they very firmly agree with democratic principles like equal rights and freedoms for everyone. So they say that on one hand, but then when they're given the opportunity to apply those in specific cases, the first gut reaction is often to try to shut down, to limit the rights and freedoms of people who belong to groups other than the groups that they belong to. And so we have this paradox that we have this attachment to principles that often isn't practiced in reality. And I think that this is a relevant framing for the way we think about human rights in HIV work, that we have an attachment to principles that when we have the opportunity, we often don't manifest in reality. And within political science, an early researcher coined this phrase, a sober second thought, calling for a norm in which people take a sober second thought and remind themselves of these principles of equality that they've already agreed to. And so, I'll talk about that a little bit more as I go through the presentation, but that's the framework that I'd like you to be thinking about as I go through these slides. Oh, thank you for the English. And so, what I want to ask is if we're ready to do the hard part. We've been places that have been hard. We've made tremendous progress, and we'll talk about that a little bit. I'm getting all my tools in order. Yet we have work left undone that is doable, and I want to ask what it will take to get there. And we'll take a little bit of a quick journey through where we've been and some of the dilemmas that we have faced, and then look at some really promising initiatives that show us better ways, more human rights-based ways that we can move forward. So we know from the first HIV cases that those first HIV cases affected people that were disregarded by society and by people in power. I'll fill in the slide in a moment. And what did we learn? We learned that there is a connection. And we started to learn a little bit about this connection between health and human rights in ways that we hadn't necessarily thought about before HIV. And so to go really briefly through this timeline that I have here, we have made, as you know, tremendous progress. We often don't talk about early HIV, but we now know that HIV was affecting people in Central Africa, and people were dying long before anyone talked about it in the West. We had a few cases in the West as well. But we moved to, in the 1980s, in wealthier, better resource countries and identify HIV. In 1981, here's a little clip from that. By the mid-80s, we'd identified the virus HIV. Of course, we weren't calling it HIV in the 1980s until after the virus was identified. By the 1990s, we have really remarkable changes, and I'm sure many of you remember the hope of the late 90s as triple antiretroviral therapy became available and became available for people, at least in the global north. We also had ACTG-076, which showed that we could largely eliminate new transmissions to babies from women who were living with HIV. I'll talk about that timeline in a moment, because then we have, finally in the 2000s, and not until the 2000s, antiretroviral therapy really expanded beyond the global north. And that's when we start to see the arc of deaths start to change. So in rich countries, we saw the arc change earlier, but globally, it's not until the mid-2000s that we see people start to stop dying and start to live because medications are made available. And so this is just incredibly promising. We have people living instead of dying, and it made all the difference in the world for those of us who've been able to get medications. And then we move into the 2010s, and now we have all of these new biomedical prevention options. We have increased life expectancy. We have increased quality of life for people living with HIV. We have all of these pills. Like, who would have thought this when many of us who have been living with HIV since the 90s for me, 80s for others, when all we had was the not very pretty and not very healthy AZT. Now we have a rainbow of pills. And look what we have to deal with now. I mean, these are wonderful things, right? Or what we are dealing with now. We're thinking about aging and HIV. I am, certainly, but we're actually studying aging because we've lived long enough to be aging with HIV. And the Paz magazine cover, this is just a delight for me. The bigger baby, the white baby on that picture is the child of my friend Reed Vreeland. Reed was born with HIV. He lost his mother at a young age. He has been able, after thinking his entire life that he would never have a family, he's been able to have a baby now who's not living with HIV. So those children of ours, the few children of ours who survived, are able now to have families of their own. So going back to this timeline, in addition to the biomedical advances, we've had a lot of attachment to talking about different areas of human rights in addressing HIV. So as I mentioned earlier, as HIV emerged, we started to talk about the connections and think about the connections between health and human rights. And so the earliest work is done by people living with HIV in 1983. People living with HIV in Denver created what they called the Denver Principles, and they said, among many other really wonderful things, we are not victims, we are only occasionally patients, we are people living with AIDS. And they demanded that they be involved in every aspect of the epidemic that affected them, that they be not seen as people who are dying, as pariahs or as victims, but as people who are central to the response. And those ideas are picked up in the Paris Declaration in 1994, in which countries, 44 countries, came together and agreed that they would make HIV, responding to HIV a priority, or made responding to AIDS a priority. They would work together, and they created and adopted what we now know as the Joopamoeba Principle, the greater involvement of people living with AIDS. We now call it the greater involvement of people living with HIV, and often, especially in Canada, I hear it called the meaningful engagement of people living with HIV. So we can call it JIPA, we can call it MIPA, but it's the idea that people should be more and more meaningfully engaged. People living with HIV should be more and more meaningfully engaged in the epidemic response. And so this Joopamoeba Principle is coined in 1994 and adopted by these 44 different nations. And then we move into the 2000s and we see declarations of commitments and political declarations, whoops, I'm getting ahead of myself, by members of the United Nations General Assembly. So the member states of the United Nations General Assembly meet and they commit again and again, every 5 years now, to having a coordinated response to HIV, largely based in principles of human rights. And these are not perfect. These are not declarations written the way that civil society would write these declarations. And many of us know and have fought battles to try to get these to be better than they are. At the same time, we have commitments from countries around the world saying largely that there should be some kind of a human rights-based approach to responding to HIV, that there should be a rigorous governmental-led approach, that governments have the responsibility for dealing with HIV. And every single one of these declarations includes the Joopamoeba Principle, that people living with HIV should be at the center of the epidemic. And I'll just note the last one, the one that was the UN Political Declaration on HIV/AIDS that was negotiated in June of this year. Very troubling in its limited attention to the needs of key populations. But one thing that is in there, if you read the text the way that I do, is that the greater involvement of people living with HIV principle, the Joopamoeba Principle, really is extended to key populations, whether or not they're also living with HIV. And I think we should be pushing for that because the language is in there. Oops, going the wrong way. On top of these UN declarations by the member states of the UN General Assembly, we've had two sets of large also UN negotiated agreements looking at the needs of the planet Earth, or the people on the planet Earth as a whole, and committing to take major action to ameliorate some of the biggest disparities and biggest concerns that people living on this planet experience. And so we had the UN Millennium Development Goals, the MDGs. There were 8 of those. One of those specifically called for halting and reversing the spread of HIV and AIDS by 2015. And remarkably, again, there's a lot of work left to do, but remarkably, that motivated tremendous work, and we actually saw tremendous progress, more progress than anyone thought possible when this goal was created by 2015. Fast forward to last year, 2016, and the UN Sustainable Development Goals were negotiated. There are no longer 8 goals in which HIV is one. There are now 17 goals. HIV is not listed specifically as a goal, which has been a concern for advocates, that HIV is not getting the kind of attention it did in the MDGs. At the same time, these goals, there are 6 of these goals that directly relate to HIV. Ending poverty, we can't end AIDS without addressing poverty. Good health and well-being. There is an HIV-specific target within SDG number 3 that calls for an end to HIV, as well as TB, malaria, and a variety of other diseases by 2030. You may have heard a lot of language around ending AIDS by 2030. Governments of the world have agreed and committed to doing this in principle. They have given us the words that they will do this by 2030 when they agreed to this Sustainable Development Goal. Other goals that relate to HIV are ensuring gender equality, reducing inequalities, which includes discrimination against key population groups, peace, justice, and strong institutions that are necessary for ending, they're necessary for ending HIV and for other many good reasons on their own, and also partnerships for reaching these goals. So what we have is tremendous biomedical progress and tremendous commitment at the highest levels to addressing HIV in a way that puts people living with HIV at the center of the response and protects human rights, at least to some extent. Now we have a dilemma at the same time, though, and that dilemma is that for people living with HIV, the clinical, social, and political reality is that living with HIV is not safe. So we can talk about human rights and we can provide medications and treatments, but on the ground, in most of our lives, living with HIV is not safe. And for some of it, it's much, much, much less safe than it is for other people. So we've been here before in terms of illnesses. There have been other illnesses that we have worried about trying to manage, control, handle, restrict people's rights. We have never, with any disease, had the kind of punitive approach that we have taken in response, as the one that we have taken in response to HIV. We have never responded with this kind of harshness. But what we have done many times is had to have a conversation about public health, human rights, and public policy, and how those fit together, and how those sometimes conflict, and about who benefits, who profits from all of the work that's being done. And unfortunately, with HIV, there's a decision that keeps getting made, this gut decision that's not in line with our human rights principles, that how we will respond is to punish and control, and to act as if there is not enough to go around. There are not enough needles and syringes. There's not enough condoms. There's not enough medication. There's not enough PrEP. There's not enough anything. There's not enough food. There's not enough housing. There's not enough education. There aren't enough jobs. Again and again, that's how we act, despite this attachment to human rights principles. So let's go back to where we started, quarantine. So everyone, I think, is familiar with the fact that Cuba had a quarantine of people living with HIV until around 1993. You may not remember, some will, how frequently those conversations arose in other countries. And it's in some ways more remarkable that only one country did it than it is that only one country did it. I want to look at a few examples of ways in which we've had the chance to have a human rights approach, and we have turned our eyes in the other direction. And so I've got needle and syringe exchange programs up on the screen, and I put 1980s, but I hope everyone here is aware that that's just a starting point. We don't have an ending point for this battle. And many of you are aware because of the great work that you've done on this issue. So starting in the 1980s, what we saw in countries around the world, especially countries where people who use drugs were on methadone maintenance programs, we saw people who use drugs dying, being sick and dying, whole generations, whole communities of people who use drugs dying from HIV and AIDS. We saw, actually similarly, we saw people who were engaged in sex work begin to die of HIV and AIDS, and we saw a whole generation of gay men begin to die of HIV and AIDS. Now, what we figured out, let's go back first to needle and syringe exchange. It became clear pretty quickly that if people were provided clean needles and syringes, that they wouldn't that they wouldn't die, that they wouldn't get HIV. And in fact, these are just a selection of a few countries around the world and their approach. What I wanted to highlight with this slide is that countries that made needle and syringe exchange programs available early at a national level essentially ended the epidemic among people who use drugs. And countries that didn't do that, that didn't happen. People who used drugs were considered disposable and were allowed to die. And that's what happened. We lost a generation of people who were treated in punitive ways instead of with compassion. So it became clear that people could be saved, that their lives could be saved, if only they were allowed clean needles and syringes. And so what did we do? In some ways, we started giving clean needles and syringes. Cities around the world criminalized the possession of one single needle on that someone had. So instead of taking the chance to save people's lives, the decision was made to control and punish. We did this with sex work. What keeps people alive if you're a sex worker? Often simply a condom. We started to criminalize anyone who carried 3 or more condoms on their person. Now, whether they were a sex worker or not, they were subject to interrogation. Now, why would we do this if we care about keeping people alive? We're controlling and punishing instead of caring about people's rights and ability to survive. Gay men, and remember, in the 80s, gay men were criminalized. All of us gay people were criminalized in almost every community in which we live. Gay men had to mobilize to talk about safe sex and came up with the first guidance for safe sex, how to have sex in an epidemic. And yet, while gay men are mobilizing and trying to stay alive, people are being locked up and incarcerated and often tortured for being gay men. And certainly we see this happening right now if people are paying attention to what's going on in Chechnya and the 100 gay men who are missing, many of which are presumed dead. And I just want to say I'm horrified at how little media coverage the situation is getting, and I can't understand why 100 gay men missing in Chechnya is an international crisis. So, but back to this. What I want to say, the final thing I want to say about needle and syringe exchange programs is that, well, 2 things. One is Canada, it looks like you guys are actually having some space opening for more needle and syringe exchange programs, but also for more safe injection sites. And I want to congratulate you and hope that the communities will be supported to bring forward their desire to have especially safe injection sites, and that will actually happen very quickly. In my own country of the US, there's not much happening that's very promising. And in fact, let me just give you one example. The city of Oakland, California, has a needle and syringe exchange program. They have had to declare a medical emergency every 2 weeks for 20 years in order to continue to make those needles and syringes available. They're not available through any kind of federal funding, even with those kinds of extreme measures. The organization that hands out the needles and syringes, I think it's about $3.5 million annually, has been burned to the ground twice. So when we think about a human rights-based approach and how far we have come, I think we also need to continue to think about how far we need to go. So here's one, a decision to punish and control that's very close to my own heart. Starting in the 1990s, which is when I had my son and found out that I was living with HIV, there was a rush of initiatives to try to force mandatory testing of all newborn babies. Now, when you test a newborn baby for HIV, all that you're really doing is testing the mother, because you don't know if the child is HIV positive. And in this period of time, there weren't treatments available, even if you found out that the child did have HIV, which at that point in time still took about 8 to 10 months, maybe a year. What happens when you test a newborn baby is you find out whether they have antibodies from the mother. So mandatory testing of newborns is actually mandatory testing of pregnant moms without their consent and often without their knowledge. So let me just show you. This is me as a very young woman living with HIV and the little baby that I had. If I could just have a moment to say, he was born 25 years ago today. And so I'm wishing him a happy birthday from here as he turns a quarter-century old. Thank you. I'll let him know. I had to hide a present for him since I'm not there. So there was this decision taken that in order to save the babies, which wasn't really about saving the babies, but in order to save the babies, all babies should be tested for HIV, and this happened in New York City, which essentially disclosed the HIV status of the mother. And instead of treating the mother with respect and concern and actually offering her a test, which we found more than 90% of mothers who are pregnant, women who are pregnant who are offered an HIV test, say yes. And I would like to suggest that anyone who says no probably has a good reason for that. No one knows her own life situation and her own challenges better than a woman who is pregnant. So we have to be able to trust people to make decisions about their lives. That's the heart of the human rights-based approach. But instead, we decide to mandatorily test newborns, even though we start to learn that moms, in research, that moms would agree to have the test anyway. So why would we do that? Well, one reason, it turns out, is that doctors were uncomfortable talking to pregnant moms about HIV, and so they found it easier to do mandatory testing of newborns than just to have a conversation that respects the health and dignity of the mother. And so we have this period of time in which women living with HIV, like myself, who, and many of us are finding out, well, many of us found out we were HIV positive when we were pregnant, some, in this case, after the child is born, are learning that the places that are supposed to care for us and take care of us actually don't have our well-being at heart. We're learning that it's not safe to go to hospitals, it's not safe to go to the doctor, because even though they may act as if their concern is for us and our child, what they're really trying to do is find out information about us that can be used, potentially even to remove our children from our own care. And related to this, what I need to ask is why, so many years into this epidemic, we continue to talk about mother-to-child transmission. It is the most stigmatizing phrase that we have, one of the most, I mean, you could probably come up with a few choice ones, but it's the most stigmatizing phrase that we use in general formal conversation about HIV. No other transmission route is referred to by the role of the person. We don't say lover to lover, we don't say man to man, woman to man, husband to wife. We don't use that in any other situation, but when we're talking about pregnant moms, the people who care the most and are most terrified that something will go wrong with their child, that they might in some way do something that limits the chances of the child that they're carrying. When we talk about that situation, then all of a sudden we start talking about mother-to-child transmission, that mothers give HIV to their babies. Women with HIV, networks of women with HIV have for years, for more than a decade, been calling for a change in language to prevention of vertical transmission, and it falls on deaf ears too often. It gets better. I don't want to say that it's never going to happen, but I really feel like I can't miss the opportunity to raise this issue, that we have this stigmatizing phrase that we can't seem to get people to stop using, that says that mothers essentially are to blame if their child is test positive, acquires HIV. And so let's talk about something that I know is or should be near and dear to the hearts of all Canadians, especially Canadians living with HIV criminalization. So we move into the 2000s, we've got a situation in which we've got many more treatments. It's much more possible to keep people alive. We've got better quality of life. We've got people living 52 years, 53 years past diagnosis. And what do? Instead of celebrating and doing everything we can to try to bring people in and make sure that they have access to treatment and all the good things and the good life that's now available, we ramp up HIV criminalization. We ramp up prosecutions of people for allegedly not disclosing their HIV status, allegedly exposing people to HIV, or allegedly transmitting HIV to someone else. And I say allegedly for a few reasons. One is alleged non-disclosure. It's often a case of a relationship. We're bringing cases in which there are two people, often at the end of a relationship, sorting out the feelings about the end of that relationship, and we are taking those into court cases and making them criminal issues and sentencing people in some cases to 25 or 30 years in prison for allegedly not disclosing their HIV status. I say alleged exposure because many of these cases have to do with spitting and biting where there's actually no risk of HIV transmission whatsoever. And transmission is rare in the cases of people who are prosecuted. I can talk more specifically about the U.S. In the U.S., only fewer than 10% of the cases that are prosecuted is there even, in only 10% or less, is there even any allegation that there was transmission of HIV. It's people who feel like they may have been exposed and are upset, and people are going to prison for 30 years with no HIV transmission whatsoever. So instead of supporting people, we decide that we need to start locking them up. And I've just got some headlines here from how this is reported in the paper. Remember, once again, we've got often cases, more often than not, in which there's no realistic possibility of transmission or no transmission whatsoever. And some of you may remember this really painful case from Canada, from Western Canada, of this 14-year-old girl who clearly needed a whole lot of things, but being prosecuted for HIV exposure and having her name, which I didn't put here, but having her name put out in the media was certainly not one of the things that she needed. So I just want to show you some maps real quickly of what's going on with HIV criminalization around the world. These are maps that we put out through the HIV Justice Network. A year ago, we'll be doing a new set of maps in the next couple of months. This slide just shows you, I hope it I guess the gray shows, okay. This slide shows you where HIV criminalization laws exist. Now, I can talk more about this than I have time for, so I'll try to keep it short. But so generally accepted best practices, the Canadian consensus statement, UN guidance, et cetera, says that that there should only be laws, that there don't need to be laws, and there shouldn't be laws that specifically single out people with HIV for prosecution. And if there is such a law, it should only be used in the context in which there is intent to harm someone else, and transmission actually takes place. And so that's sort of the best practice guidance. What we have here are laws that are vague, that are used arbitrarily, and that, again, prosecute people often for things like spitting and biting, or even for being pregnant and HIV positive and having, you know, a child in your womb because you've then exposed that child to HIV. So these are the countries in the world that have these laws that are not best practice laws. There are 72 countries, actually 71, because Kenya gets taken off that list. There was a wonderful court ruling there last year will be reflected in our updated map. So 71 countries in the world that criminalize HIV through the law. Now, you might have noticed Canada wasn't in that list, but here you are, because you don't have to have an HIV-specific law to criminalize people with HIV. And in fact, in Canada, people are prosecuted under sexual assault laws, which is a bit terrifying, because what it says to me as a woman living with HIV, that if someone were to go to the police and say that I had had sex with them and I hadn't disclosed my status, I would be charged with aggravated sexual assault. I would be told that I had not only raped them, sexually assaulted them, but done that in its worst form. And so you see Canada does prosecute people, as do other countries, even when there isn't an HIV-specific law. And this slide here just shows you briefly where prosecutions have taken place recently. The top 3 countries in the world in terms of numbers of people prosecuted are in order: Russia, US, Canada. And so that's part of the reason that there has been a lot of activity mobilized around responding to criminalization. And in a few minutes, I will tell you something that you can do today to help respond to that. But let me first go to back to this idea of the tolerance paradox. And what I want to highlight here, because we've talked about this idea that people's support for tolerance in general is much more difficult to see when we have specific cases, and when groups that those people don't see themselves as part of are involved. This little needle that I have, or syringe that I have up here, what I want that to demonstrate, or what that symbolizes, is the way I think about political tolerance, which is that I think we need to be inoculated. I think we need to think in advance. We know that people in general seem to have a gut reaction that's intolerant. It would be nice to think that all of us are somehow different than everyone else in the world that's studied, but I don't think that that's reasonable, and I think it's actually quite dangerous. I think we ought to expect that most of us will also need to have a sober second thought, that we also have this gut reaction of intolerance against human rights when specific instances are brought forward in which people need supporting care. And so what I would argue is that we need to be inoculated. We need to be prepared in advance to say, I'm going to have this sober second thought toward human rights. And how can we do that? We can do that partly by reflecting. Whenever we have a program, a research study, or any kind of initiative, think about what are the assumptions that drive this program? What are the assumptions about people living with and most affected by HIV? We can ask, how would the diversity of people living with HIV respond to this? And what are the most predictable outcomes? It's so rare that this ever gets asked. What are the most predictable outcomes of this research or this initiative on the lives of those with the least political and economic power? Further part of this inoculation is paying attention to the Joopamoeba Principle. And I wish I'd written MEPA, M-E-P-A, to be much more supportive of my Canadian friends. So I've got that now. But Joopamoeba Principle. And I've just listed 3 here. We've got the global network of people living with HIV. We've got the international community of women living with HIV who are available in all regions. And you have, I'm really delighted to say, a new network of positive people in Canada, the Canadian Positive People's Network. And I apologize for all the networks that are not listed on this slide. Yeah. further inoculating yourself, as you think about the social science research agendas that you will support, how do you support community-developed research agendas, research that is community-informed, community-led, community-assisted data analysis? Don't think that people without HIV who are not part of a community can analyze data properly without the input of the people who've been studied. And we need community-owned research results. We also need funding for communities to be able to do this. I don't understand why everyone is supposed to get paid to do research except for communities. And I know that in Canada, you've done better than many countries in making sure that peer researchers are paid, but I can't emphasize enough how much that funding is needed. So some ways to really address this human rights gap. One example is through challenging HIV stigma. And we have a program, the People Living with HIV Stigma Index, that has been initiated in more than 60 countries, in which people living with HIV drive the research, are trained, are hired, are supported, and interview other people living with HIV about their experiences with stigma and discrimination. And I am particularly delighted to note that Canada has just received funding for a multi-province stigma index implementation. And so huge congratulations to all of you who've been involved in the 3 or 4 year process of asking for funding that it's finally come through. We've also been active in ending HIV criminalization. So I showed you the bad slides. Here's kind of my favorite slide. This slide shows that new laws and existing laws are being beaten back by concerted community action. And so we can see that HIV criminalization is contested terrain, and there is room for change to happen. I'm not going to go through all the details. I'm happy to talk about it later. But I want to add that with the Canadian HIV/AIDS Legal Network and 6 other organizations worldwide, we have created a global collaborative called HIV Justice Worldwide. Check us out on the web, to work together to coordinate a response to ending HIV criminalization. And I said that I would tell you what you can do. And what you can do, let me see if I can pull this up. At 12:30 today, there is going to be an action calling on the Quebec Minister of Justice to stop prosecutions in Canada. It's going to happen here in the conference concourse. We're asking people to participate and to get your Twitter accounts ready. There are a number of tweets that have been prepared that can be sent. There's also a simultaneous list of tweets for Ontario where the most prosecutions in Canada are happening. So please join us at 12:30 for that action. Thank you. Yes. So you'll be making HIV Justice Worldwide a reality with us. There are so many fabulous programs happening in Canada that are led by communities. I want to highlight what the work of the Canadian Aboriginal AIDS Network, and I thank Doris for spending quite a bit of time really helping me understand some of the work that they're doing. Well deserved. I won't go into the details, but what I will say is this is a remarkable, there are 2 remarkable programs we talked about. I know there are more: Envisioning Health, work for women living with HIV, work by and for, together with women living with HIV, building on women's strengths to respond to their needs and the needs of other women living with HIV who are Indigenous, and the Stable Homes, Healthy Lives Initiative. I hope I said, Stable Homes, Stable Homes, Healthy Homes Initiative. I got it wrong. Stable Homes, Strong Families. Stable Homes, Strong Families. Thank you. I needed you in the front row. Stable Homes, Strong Families, responding to homelessness, again, by working with Indigenous people, doing work by and for Indigenous people, responding to homelessness in a way that values people's lived experiences and supports them as they choose to live lives and pull lives together in the ways that work for them and give them meaning. And so I really encourage you to talk more. I really want to see more about how we can bring those kinds of approaches into research more broadly. So just to close, this is a picture of the bridge between Detroit and Windsor. I'm from Detroit. We're in Canada. This is our bridge. It's beautiful. What I want to say is that we are nearly 40 years into the epidemic, and we aren't close to being done yet. We have legal and political structures that still continue to systematically marginalize people instead of protecting them. And we have people thinking the epidemic is over because some people in some situations can get very good quality treatment and can live really good lives. And that is something to be pleased about. But that should be all people everywhere have access to good treatment and really good lives. We have global messaging that says we're ending AIDS, that we're getting to zero, we're having an AIDS-free generation. And while it's true that we have made great progress, This progress demonstrates that we still cannot treat our way out of an epidemic that is rooted in injustice. And we still cannot punish and control our way out of an epidemic that is rooted in injustice. And I'm talking about economic injustice, political injustice, and social injustice. And we are approaching the reality that it's us, the people leading the HIV response, who are the ones that need to change. We need to think about how we stop being violent toward one another. We have to confront that it is us, and it's up to us to make that change. Our attachment to development and to ending poverty needs a sober second thought. Our attachment to health and human rights needs a sober second thought. Our attachment to human rights, our attachment to health rights needs a sober second thought. HIV is asking us to draw these conclusions. HIV is asking us to be a human family who does things differently. Thank you. Thanks. Thank you. Thank you. Thank you.
You did so well. It's so good.
You're nodding in the same person.
What's this? I don't know. It's a gift from CAHR.
Oh, thank you, CAHR. This
Thank
is
you so
lovely.
much. And this was exactly what we needed. Thank you. And while we're getting ready to bring the other plenary speaker, I just want to invite Ron Rosenes to complement what Laurel has said about the action today.
Thank you. Good morning, everyone. And thank you so much to Laurel. She got my heart beating so fast, reminding us about all the hard work we have to do. In addition to the demonstration today, which is going to take place at about 12:30, and I think just outside in the public space, I also want to take a moment to really thank the board of CAHR for supporting the statement by the original co-signatories of the 2014 consensus statement on the risk of HIV transmission, for supporting a new and updated statement which really urges the Federal Minister of Justice, Jody Wilson-Raybould, to sit down as she promised to do last World AIDS Day, to meet with her counterparts at the provincial level, the provincial attorneys general, in order to really take a close look at enacting measures that will mitigate the overly broad use of the law to criminalize people. And so today we have an amazing opportunity, one that's really underlined by everything that Laurel told us, an amazing opportunity to put some pressure on the government and to meet with the provincial counterparts and look at such measures as prosecutorial guidelines and other ways in which to mitigate the inappropriate use of the criminal law in Canada. So we hope that you'll also tweet about that. Take a look at the statement, and we're expecting some media which will help us shine a light on this very opportune moment to get our ministers of justice to do the work they need to do to lessen the risk for people in terms of disclosing their HIV status. Thanks very much.